And I'm going to introduce our first panelist, Dr. Scott Hammer, attending physician, chief for the Division of Infectious Diseases, and representing both the College of Physicians and Surgeons and Mailman School of Public Health. And my first question, Dr. Hammer, is, what is Ebola? How is it transmitted? And what is the incubation period?
Thank you, Kathleen, and thanks to the organizers for inviting me to participate on this panel. I'm going to be brief with each question so we can leave time for all the panelists and for questions. So what is Ebola? Well, first, I think given the mixed nature of the audience, we have to step back and think about pathogens per se, and viruses, of course, are a major area of infectious diseases, which have been recognized more and more in the era of molecular biology. Ebola virus is a frightening term, if you will, but it's part of a group of the family of viruses of Filoviridae, which are these filamentous virus particles, which cause frightening disease when they're full blown. Ebola was first diagnosed discovered in 1976. A related virus, the Marburg virus, which also causes a hemorrhagic fever syndrome, was discovered in Germany in 1967. There have been about 30 outbreaks of Ebola virus over this period of time, but the one we're seeing in 2014 is very different and much larger than any of the others. Viruses are RNA or DNA particles. They do not replicate on their own. They need to parasitize the host cell in order to replicate. And this is one of the insidious issues about viruses. They hijack and they co-evolve with humans or their natural hosts. Ebola is transmitted first. Probably the reservoir is uncertain, and others should comment on this, particularly Steve. But fruit bats are thought to be one reservoir. The virus can infect non-human primates, and bushmeat can then infect others. Once an individual is infected, the incubation period is up anywhere from 5 to 7 to up to 21 days, and the transmission from human to human typically requires intimate contact, close contact with infected secretions. I think you've all read this in the New York Times and seen it on TV, and if you've not been directly involved. And the virus can replicate in almost any cell in the body, and body fluids, that is blood, urine, semen, saliva, sweat, etc., can carry the virus. The greatest risk in the community is for those who take care of infected family members or friends, or those who go through ritual burial rites. I'll stop there.
Can you tell us how the diagnosis of Ebola can be made?
Thank you. The diagnosis is difficult at the beginning unless you're in an epidemic situation. So taking a history as a good physician or public health practitioner is really important. If somebody presents typically with fever after the incubation period, the fever is typically the first symptom, with nonspecific aches and headache and myalgias, it's a difficult differential to make. However, if you ask the history, have you been in contact with someone who died or is ill with Ebola, you can fix right in on that. And in an epidemic situation, a probable case definition is put together. So the first is your clinical acumen. Second, and the laboratory confirmed cases are those that require an RT-PCR test or an antibody test. But typically it's the PCR test. And the issue with the PCR test is that it can be negative for the first 3 days after symptom onset. So you've also probably read about that. And so the test is sensitive, but not sensitive enough such that fever, once it starts, may be associated with a negative PCR test, but 3 days into symptoms or more, it'll turn positive.
What are the clinical courses that are seen in the disease?
The courses that are seen are variable, but in about 40% of cases, and the data are still coming in, and there are 15,000 cases to date with 40% mortality, 45% mortality. The courses that are seen are, the courses that are seen are one, recovery, so that you can go through an initial phase of an influenza-like syndrome or a flu-like syndrome, non-specific. Immediately thereafter, 3 to 5 days later, you go through a gastrointestinal syndrome characterized by abdominal pain, nausea, vomiting, and diarrhea. This is the major key second phase, where extreme volumes of fluid loss can occur. Individuals can become profoundly dehydrated, need to be rehydrated, and this leads to shock and death in 40% at least of individuals. The mortality can be as high as 60 or 70% in others. So it depends on where you are and which the pathogen is and the viral titer. In about 40% or 45% of individuals, in the natural sequence of things, after the diarrheal phase, they will continue to get better and better, and they can be released after their RT-PCR is done and is negative, usually 2 or 3 times.
Could you tell us what treatments are being investigated?
So there are a number of treatments, none of which have been proven to work, but there are at least 5 different treatments out there in the experimental world. ZMapp, monoclonal antibodies against the virus, which are in production and have shown benefit in animals. Brincidofovir and a number of other antiviral drugs have been taken off the shelf, or that are being looked at for other viruses are being looked at as well. None of these have only been put out in isolated situations, and none have been proven to work thus far.
Tell us a little bit about the prospect for a preventive vaccine.
So the preventive vaccine arena is really exciting. There are 2 vaccines that have shown 100% protection in non-human primates that have been produced, one by a Canadian firm that's now been moved to an Iowa group, and one by the VRC in collaboration with GlaxoSmithKline. And these are vaccines that utilize a viral vector, to deliver the payload of an important gene and protein that hopefully induces immunity in its host. The immunity to Ebola is probably antibody and CD4 and CD8 cell mediated, but we don't really know what the immune correlate of protection is in humans. The New England Journal just published online the VRC's experience with a phase 1 trial of an Ebola vaccine, and that vaccine, by the government in cooperation with the agencies in West Africa and the government representatives, is going into a planned phase 2B trial after the first of the year.
Thank you very much, Dr. Hammer. I'd now like to introduce our next panelist, Dr. Stephen Morse, who's Professor of Epidemiology, the Global Co-Director of PREDICT, and also representing the Mailman School of Public Health. Good morning.
Thank you very much.
Dr. Morse, what do you think are the greatest misconceptions about Ebola?
I think the biggest misconception, and thank you, Scott, for doing all the heavy lifting there. I think the biggest misconception is this talk about Ebola somehow mutating to become airborne, and spreading like the flu. And that's good material for Hollywood, but I think we've never really seen it happen in real life. We can't rule out any possibility, but I think it's less likely than my being struck by lightning right now.
How great a threat is Ebola to the United States as a potential pandemic?
Well, actually we're obviously all concerned about Ebola because it's such a terribly devastating disease, and it can have such, tremendously harmful effects. It's a terrible thing to see, and even those who survive often are, they do recover, but they're often look terrible while they're sick, as do all people. You heard about the many very serious symptoms. So we naturally fear it. Hollywood has done a lot to add to that, I think. But related to the earlier question, Ebola has its own natural history, its own environment. As Scott mentioned, it probably is a natural infection of fruit bats. People normally get it in forested areas in Central Africa or other parts of Africa where they may come in contact with fruit bats or with other animals like apes, some other non-human primates, some types of antelopes called duikers, and some other mammals that can also get Ebola, die of it, and then, of course, in a protein-poor world, you see this fresh carcass, take it home, and unfortunately share what turns out to be a dangerous meal. But in the U.S., this same type of ecology just simply doesn't exist. So all of the cases we've seen here that have not already come in with Ebola have been in healthcare workers. And that's because, very simply, they are coming in close contact with the people who are the sickest and have the highest levels of virus. And they need to observe very rigorous infection control precautions, which I think Lane Larson will be talking about in a moment. So we have had 2 people come in with Ebola that was not immediately diagnosed, was diagnosed quickly. The first one in Dallas, which I'll come back to in a moment. And he went around for several days symptomatically, and we believe that nobody can actually transmit the disease until they start showing symptoms and until there are bodily fluids that are infected that you can come in contact with. But in Dallas, this particular patient, Thomas Duncan, in fact, infected nobody he came in contact with except 2 nurses who probably were not properly prepared by the hospital in which they were working, who took care of him after. So there really isn't a potential pandemic potential. There isn't really pandemic potential for this virus. Basically, it's something that if we contain it, if we handle it, we can not really see it as a threat to the U.S., but it's a very big problem in Africa, and that's where it really needs to be controlled.
So you've talked about containment, but are there some other things we need most to control this outbreak?
People. The biggest shortage right now, although treatment facilities, which the U.S. government and other governments are building, some in Liberia and elsewhere, are necessary. The infrastructure is necessary. You need a lot of water to do many things, including decontamination and treating that dehydration you heard about. We need people who can actually deal with the patients, clinicians who can help to care for the patients and bring them over this period when they're sick, and others, epidemiologists, who can do contact tracing to find out who else might be in contact with the virus and watch them so that they can be taken care of if they should come down with the disease. Basically, we have a shortage of people, and we have a shortage of people out there in the communities to communicate this information and inform people where most of the illnesses are happening, places where they're not bringing people to the hospitals.
Are there some key lessons from this outbreak?
Yeah, I think one of the key lessons is that our fear of Ebola, I think, has been disproportionate to it's a very frightening and obviously a terrifying disease to see. Hollywood has made it worse, but it's still extremely unpleasant. There's no question about that. People are very sick when they get it. But except in a situation like what we're seeing now, the biggest Ebola outbreak in the history of this disease since 1976, nothing has changed about its transmission. Nothing has changed about the way we would control it. And I think we need to learn how to really do science-based approaches rather than be driven by fear. And unfortunately, politically, as we saw in the run-up to the last election, there was tremendous, intense interest in it, in part part because it was a very good political issue for people running for office. They could show how tough they were. So a key lesson is that we need really to think about it as a disease that can be dealt with by science. Secondly, and good medicine. Secondly, it needs really recognition early. What happened in Dallas is I think really a case study of all the things that were done wrong, one of which was not to take Duncan's travel history seriously, not to take his report of symptoms seriously, and a lot of lives could have been spared. Certainly, his life could have been spared, and many efforts in contact tracing could have been spared if he had been put into isolation properly at the beginning. So people need to be informed, not perhaps feared of the virus.
Thank you very much, Dr. Morse.
Thank you.
Our next panelist, Dr. Elaine Larson, is the Associate Dean for Research at the School of Nursing. She's an expert in infection prevention, editor of the American Journal of Infection Control, and is here representing both the School of Nursing and the Mailman School of Public Health. And on your chairs today is a copy of the Institute of Medicine workshop, for which Dr. Larson was a member of the planning committee and raconteur. Dr. Larson, in regard to the recent IOM meeting, can you briefly share some insights, new recommendations in infection control?
Sure, but first let me give you a little context about what we're talking about when we're talking about isolation and personal protection equipment and barrier precautions. The CDC has published contact isolation and isolation guidelines, which we now call barrier precautions, for at least several decades. And quite honestly, most of what we do is based on clinical experience and sort of theoretical, what we know about transmission of diseases. So the few studies that have been done to really look at the efficacy of contact precautions or barrier precautions have not been very clear. And it's unclear because it's hard to differentiate between whether wearing a gown, gloves, mask, etc. are actually working, or whether people just aren't doing it right and doing it thoroughly. So when I started as a nurse, one of the first places I worked was an infectious disease unit, which we don't have anymore. The TB sanitariums have closed, the infectious disease units have closed. But we had in each room an anteroom where we donned everything, put everything on, the gloves, all that stuff, went into the patient's room, then we came out, took out off the equipment, and we had a second person watching us to make sure that we didn't contaminate ourselves inadvertently. So really what we need, and the recommendations for the IOM report is we need better studies about what exactly works in terms of personal protective equipment. We think we know because based on transmission. We need to know what are the best ways to train people. And really, we need to know what are the work systems that have to be put in place that make it easy and possible for people to follow the recommendations. So that's why hospitals are doing a lot now with working on the systems of providing care to such patients.
Thank you. In terms of protection for healthcare workers, will the usual personal protective equipment that is used for isolating infected patients in hospitals work? Or are there other precautions that are needed for Ebola?
Well, as both of the previous speakers said, a patient with Ebola loses up to 10 liters of fluid a day, sweating, vomit, and each one of those body fluids is highly infectious. So yes, we do need very good contact precautions for taking care of Ebola patients. And the problem is that many of the healthcare workers have sort of, we have to go back to the basics. They've sort of lost the expertise that it takes. And donning and doffing, putting on and off this equipment isn't easy. It's not easy to take off a pair of gloves without contaminating yourself. So it does take training. And that's why there's been a lot of training. For example, in New York, the Greater New York Hospital Association had a training session at the Javits Center and thousands of people attended. People from CDC came, demonstrated how to take on and put off the equipment. And we really need people who are specially trained, because the more you do it, the better you get at it.
Is our healthcare workforce prepared to care for Ebola patients?
Well, as I said, I think we need, we've all the hospitals have been sort of upping the training. People are getting trained, they're having return demonstrations and so forth. It's unfortunate in some ways that the hospitals in New York have not sort of collaborated more, because each hospital is sort of doing their own thing, and that's kind of an expensive and an inefficient way to do it. So, for example, Columbia has in the Allen Pavilion a whole containment area ready, prepared, and we really need to be efficient with the way that we train people and give them the experience they need, because practice, just like a surgeon, the more she or he does a hip replacement, the better they get at it. The more a healthcare worker practices taking on and off the equipment, the better they get at it.
So you talked about how hospitals are preparing to protect the staff. Are there sufficient supplies of personal protective equipment available?
Absolutely. I mean, this country has more supplies than anywhere else in the world. The problem is distribution sometimes, and use and misuse. Sometimes we waste equipment. We waste actually a lot of equipment. If you go into the hospital, you see people wearing gloves for everything, even when they don't need to. So we have equipment. What we need is distribution systems, and quite frankly, I agree with what Dr. Moore said, and that is we need to work in Africa. This is a global community. So we are, freaked out here about 5 or 6 cases, all of which came from West Africa, when we should be thinking about what needs to be done for the global community.
Thank you very much, Dr. Larson. I'm going to take a few moments to talk a little bit about what is going on at New York Presbyterian and Columbia University. My background is I've spent greater than 3 decades devoted to workplace health and safety, both as a clinician and as a safety professional. And I'm in the privileged position to be responsible for environmental health and safety throughout all of Columbia's campuses. And taking some lessons learned from pandemic planning, we've been able to apply some of those processes to develop an Ebola plan. And if I were to say a few quick things that are really important for the university and New York Presbyterian, being a tertiary care facility, is plan, communicate, educate, drill, repeat. And I can't say that enough. The importance of being nimble and flexible, putting a plan down and then modifying it as the course is better understood, to take an interdisciplinary approach so that take down the stovepipes, look across all areas of operations and how we can work together. With a very complicated structure like Columbia and New York Presbyterian, we have New York Presbyterian Weill Cornell, we have New York Presbyterian Columbia, we have Columbia University Morningside, we have Columbia University Medical Center, and then each entity have all of our affiliates. And it's important to be able to work together on a plan that protects our patients, our faculty, our staff, and at Columbia University, our students. It's taken a top-down approach, working from the provost, and Dr. Hammer is a part of that provostial committee that sets forth processes in place for the university that are in synergy with the hospital, considering we have a medical school, a nursing school, a dental school, a school of public health. And then developing an operations work group, which we have the pleasure of and privilege of having Dr. Morse be our scientific effort, along with our directors of student health services, to develop a plan to protect, again, our students, our faculty, and our staff. The use of multimedia communication, using email, websites, town hall meetings to talk about Ebola. What does it mean to the college, to the hospital, to the faculty, to the staff? And educate. We have developed huddles, online training, classroom training, We took advantage of the Greater New York Hospital Association, but training goes beyond the clinicians. We talk about our public safety officers, our security officers who are here 24/7, our custodial staff, our facilities engineer who are adjusting HVAC, and the importance of providing clear messaging about disease transmission. This is not influenza. This is bloodborne pathogen. And so that they can understand how they can do their work 24 hours a day, 7 days a week. And what we've taken is we took the Greater New York Hospital Association training, and as Dr. Larson pointed out, the importance of practicing donning and doffing. Very, very critical. Dr. Larson talked about having the buddy system when you don and doff, and just knowing how to take off that outer layer of glove or that outer gown. And so we've set up practice sessions in our student health services and in our faculty practices so that clinicians can practice how to don and doff. And then we repeat this, right? We've had this wave of the Ebola cases. Of course, New York had a faculty member, our emergency room physician, the first case in New York. And we need to recycle this and keep the information fresh. Another point is that we can't train all 20,000 New York Presbyterian Hospital and Columbia University faculty and clinical staff. It just isn't possible. So the importance of having expert teams, as we called hammer teams, it actually came from when we knocked out anthrax back post 9/11, as you had these highly specialized elite persons who are expert in Ebola and Ebola care, much like as what we've done up at the Allen Pavilion in creating a unit so that that case can be properly taken care of. So again, just a moment to take a little time out and tell you a little bit about the application of what we're talking about today. And I'd like to now resume with our fourth panelist, Dr. Wafa El-Sadr. She is both a physician and a professor of epidemiology, a researcher. She's an expert in building public health and health systems capacity, and she's representing both Mailman School of Public Health and the College of Physicians and Surgeons. Good morning, Wafa.
Good morning.
You've recently been in Sierra Leone during the Ebola outbreak. It's really hard for us here, despite the media coverage, to appreciate what it must feel like to be there. What struck you about the situation in the country, and what are ways in which the Ebola outbreak is or is not evident?
Thank you very much for the opportunity to be here with my colleagues. And I think I think nothing really prepared us for myself and Susan Strasser, who's a colleague of mine at ICAP, for arriving in Sierra Leone and facing immediately the Ebola outbreak right there on the ground. In many ways, I think Ebola dominates every aspect of life in the country. From the moment you land in the airport till you leave the country, it dominates every aspect of people's lives. What we were impressed with, were the intensive communications that have been, methods that have been established in the country around Ebola. You see billboards about the symptoms of Ebola, what to do if you suspect Ebola everywhere in the country, in the cities, in the countryside. You see banners that, again, are telling the population about Ebola. There's a whole mobilization, attempt at mobilizing the whole population around this threat. I think also you can feel the efforts by the country itself to control this amazing and frightening outbreak. There are some controls on travel. There are checkpoints around the routes where they do check for symptoms of Ebola, and they take people's temperatures. All the schools in Sierra Leone have been closed since March. That means primary schools, medical schools, nursing schools. Everybody's at home. All the children are at home. There are no schools. There's no gathering of people allowed. There's a no-touch policy in the whole country. You can't touch anybody. We could not touch anybody for the week we were there. Very unsettling to live through this experience, in all honesty. On the other hand, I also saw a remarkable collaborative spirit. The international community, the local organizations, everybody working together, really trying to make a difference. And I have not seen this before elsewhere. I've been working in Africa and Asia for a lot of years. And the way people come together and the way people are trying to complement each other's work is really remarkable. And I think it offers a fantastic opportunity for the Columbia community to demonstrate that we want to be part of this. We want to be part of this response because the doors are open and the people have open arms for us. And lastly, I think also that very importantly is the economic impact and the social impact of this outbreak on the people of this country. You can imagine when there's no people coming in, businesses are staying away, business people are staying away, investments that were promised are not coming in, the port is empty. There's a huge economic impact on this country that's going to last beyond Ebola. So I think the impact is palpable. It's really palpable, but I think also the response is palpable, and I think the opportunities are really very obvious and very palpable.
Why did you go to Sierra Leone?
I think as somebody who's been trained in infectious disease and trained in public health, I feel that that's everything I've been trained for in my whole life is really to be there and to try to help in that situation. It is critical that when something happens like this, that I think for those of us who bring those assets, who have this experience, we need to be there. We need to contribute to the response. And that was a very strong feeling that I had and my colleagues had and at ICAP, is that we could not just sit far away and hope for the best. We knew we had some skills and we had some people and we had some commitment, and we were really eager to see what can we do. What can we do? Is there something that we can do that we can bring to the table? And that was the reason why we went to Sierra Leone.
You are a public health researcher and practitioner. What are ways in which public health can respond to the needs on the ground?
During our visit there to Sierra Leone, what we did is we had a lot of different meetings. We met with the UN response team. We met with WHO, UNICEF. We met with the Ministry of Health, with DFID, the UK military, who are responsible for the Sierra Leone response, IRC, MSF. We met with a lot of different people, had a lot of different discussions. We visited the countryside to get a sense of how the Ebola response is being done at a district level. And I think out of that, we arrived at an important conclusion, which is that public health has a lot to contribute to the response in Sierra Leone. Clearly, there's a need for people who provide care, meaning medical doctors who are there in the treatment units. They're very, very important. The medical care, the nursing care for the patients is very critical. But in reality, what's going to control this outbreak is the public health response. It is about finding cases. It is about contact tracing. It's about containing transmission. While we await, new treatments and new vaccine, but it has to be a robust public health response that will make a difference. And what do I mean by that? I mean thinking about the building blocks of the health system, the workforce. You have to train the workforce. You have to find the nurses and train them and how to protect themselves. You have to develop the systems for distribution of PPEs, protective equipment. You have to help them develop a system for transport of lab specimens. You have to find a system to do the surveillance and collect the data and look at the data and examine the data and use the data. You have to develop a system for communicating with the community, engaging the Ebola survivors. All of these activities that are focused on the building blocks of the health systems are at the core of what public health is all about. And I feel like we can craft a public health response by focusing on the assets that public health brings to such a situation, by focusing on those very specific gaps that we identified when we were there on the ground in Sierra Leone.
Through ICAP, the center that you direct at Mailman, you and your team have established large-scale programs that have impacted the lives of populations around the world. What are the lessons learned from the HIV response that can inform the Ebola response?
Many, many lessons. There certainly are differences between Ebola and HIV, but there are lots of similarities. And beyond just the stigma and the suffering and so on, there are lots of similarities, and particularly in terms of the response. I feel the one lesson learned is to anchor, very important, anchor all our actions in science and in evidence, rather than in fear and hype. I feel that that's the message. And I think that's what we learned from HIV, is to stick with what the evidence tells us and really stick with what the evidence tells us and not to waver from that. because of fear or political imperative or because of other imperatives, just anchored in science and minimize the hype. What we found from ICAP is what we have learned is building those partnerships on the ground, the partnerships with the ministries, the partnerships with other people who are helping respond on the ground. Those partnerships are very vital, the partnerships with the community, garnering the confidence of the community and their trust in us is very, very vital. And also, yet the use of multidisciplinary teams. Our work is really based on bringing people with different expertise, the clinician, the public health professional, the nurse, the logistician, the laboratorian. It's all about multidisciplinary teams. That's all our work in HIV, and that's exactly what's needed in Sierra Leone now. So part of it is bringing those same skills and those same assets and adapting them to Ebola, and then trying to work with partners on the ground to see if we can accomplish what has been accomplished with HIV, but do it much faster, because this is an acute outbreak, and try to bring this outbreak to an end. We have to do it. The longer transmission goes on, the more difficult it will be to bring it to an end, and therefore mobilizing this response is absolutely imperative as quickly as possible.
Okay, well, that wraps us up for today. Thank you for this morning's panel. It's been a great audience.